saw yesterday. Yes.
The live streaming.
The live streaming.
Oh, yes.
Live streaming. It's fabulous. The first thing that we want to do is, I'm going to do this. We're going to bring up our next speaker, and I'm going to get this name right. Dr. Sadate. Give me a high five. That wasn't right. Okay. I was really excited because I thought I could do it, but I'm going to go ahead and tell you his bio, and then he's going to tell you his real name. He participates in the evaluation and treatment of individuals of all ages with birth defects, intellectual disabilities, and other genetic disorders. He's also involved with teaching medical students, residents, and genetic counseling students. Area of interest include connective tissue disorders and craniofacial anomalies. Please welcome him.
I was shamed.
Speaking of shame, yeah, thank you so much. Well, thank you, Julie, for the introduction. Thank you, Jody and Karen, for the invitation. My only disclaimer really is that I'm not a cardiologist. The way you can tell is that I don't wear suits, as we were talking about shame, comparing myself to former NFL stars and cardiothoracic surgeons and cardiologists. So I don't really wear suits, other than weddings and maybe funerals. But anyway, so thank you again. So I'm a geneticist by training. So today I wanted to talk a little bit about the impact and implications of genetic discoveries in congenital heart disease. So here are my objectives for this brief talk. So I wanted to review the current and new technologies as far as genetic testing goes. To talk a little bit about the causes of congenital heart defects, not only genetic but non-genetic as well. And lastly, to talk a little bit about why it matters if somebody has a genetic underlying diagnosis in the setting of congenital heart defects. So I need you to go back several years to your biology classes, and this is important as we're talking about some of the genetic testing. So just to remember, so all the cells in our body, inside the nucleus, we have our chromosomes, right? So the chromosomes is where all the DNA is tightly packed, where all the genes are. So if you go from bigger to smaller, from left to right on your screen. So at the gene level, so we have the famous double helix here, and of course, you know, you remember each letter pairs with a different letter. And really the genes, again, are the instructions that will allow us to produce the proteins that ultimately is what has the function in our bodies. So when we talk about genetic testing, and many of you may have experienced it directly or a family relative, so there are different ways that we can look at the genetic information. So when we talk about cytogenetics, so we're talking about looking at the chromosomes, that's what we call a karyotype. So we stain it and look under the microscope after isolating the DNA from either saliva spit or blood. When we talk about FISH, it's really just a stain of a very specific area of a chromosome that allows us to look at very specific areas, really kind of phasing out now that we have this other test that many of the kids with congenital heart defects have done, which is called a microarray, also known as CGH. So what that test does is really looking at your chromosomes, but at a very high resolution picture. The computer kind of reads it, and ultimately it's the same. You're looking for pieces missing or extra throughout your genetic information level. And again, we're still on the bigger side of things. So if we want to look at the gene level, then we need to look at the spelling of each individual gene. So we have different ways to look at the spelling of one gene or a bunch of genes in what we call next generation sequencing or next gen. And then the newer technologies is what we call whole exome sequencing, which is here, or whole genome sequencing. So those tests allow us to look basically at all the genes as we will review. Looking at one gene at a time, very rarely done nowadays unless you have a very high suspicion that there's a very specific diagnosis going on. So we look at the spelling, the letters, and then we compare it to what we know is the normal or the reference. For example, so the CHD7 gene is responsible for a genetic condition that is very high prevalence of congenital heart defects, which is called CHD syndrome. So very easy, if I have a high suspicion, I test for that gene and look at the spelling, and then I hopefully can find a mutation that will explain kind of what's going on. So that's one gene at a time. The next level is looking at multiple genes at a time, which again, that's called next generation sequencing. Not gonna go through this, but again, the idea being that you're looking at multiple genes all at once at the spelling. So for example, there are a variety of panels that are targeted for congenital heart defects. Again, I'm from Arkansas Children's, and we're not really a bigger hospital or as big as Texas Children's, but we even have a panel for congenital heart defects. So I'm sure Texas Children's will have an equivalent. So again, there are some genes that we know are more likely to be mutated for very specific heart defects. So there's a way to look at that. And then the latest or fancier genetic testing, the bigger test that we have at the moment is called whole exome sequencing. So briefly, what you're doing here is just looking at every single gene in your body. So we all have about the same amount of genes, which is 20,000 genes. So this test allows us to look at the spelling of all the genes, but with a caveat for that. So you're looking at the parts of your genes that we know are responsible for producing proteins. So that's called an exon, right? So we're looking at all the exons. So here, 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 here. But we're not looking at the introns, which is the parts that are in between exons, because we don't know exactly what the introns do. We believe that the majority of human diseases will be caused by mutations in the exons anyway, which again is that part. So this test, whole exome sequencing, allows you to look at the spelling of what we believe is the most important part of your DNA. So that's that. And just as a reminder, when the whole Genome project was completed, that was over 15 years ago, the cost for that was over $100 million total. And nowadays, actually, getting the sequencing data, so looking at if I want to get whole genome testing or whole exome testing, is not really that expensive to get the raw data. What takes the most time and the value of the test is the interpretation of the data. As you can imagine, is a lot of information and not the easier thing to do. So still, if you want to look at all the genes in your body, it is possible with that test, whole exome sequencing. And that test is going to be a little bit more expensive, as we will review. So there are some limitations as far as genetic testing. So interpretation, as I was saying, is difficult. The more genes you're going to look at, the more likely it is that you will find some kind of misspelling. But not all misspelling have clear interpretations. So sometimes we find what we call variants of no significance, which means that there's a misspelling, but we don't necessarily know what that means. So in the ideal situation, every time anybody goes through genetic testing, there should be some kind of genetic counseling to know what that entails. And a brief overview about cost. Again, every center has different prices. But in general, so microarray, which again is that fancy computer test that is looking at pieces missing or extra throughout genetic information, it's about a couple $1,000s. The panels of genes, so the next generation sequencing panels that we do is about $2,000 to $4,000. And then the most expensive test is whole exome sequencing, which is about $5,000 to $7,000. That is clinically available. It's not really research. Now, the fancier test, which is that whole genome sequencing, which you're looking at everything in your genetic information, is about $16,000. I've never ordered that test before. I was actually surprised to see that it was clinically available just last week, but again, it's about $60,000. So I'm sure that not many insurances will pay for it. Whole exome, I've sent a bunch in the past. So the turnaround time for testing, it depends on what you're doing. So the more complicated the test, obviously the time wait will be longer, but we're looking about 3 weeks for the smaller test and 4 months for this test, whole exome sequencing. There are limitations as far as insurance coverage. Again, every insurance will have their own policy in place, and you guys will have your own individual policy. There are some insurance policies that are no genetic testing, period. For example, Arkansas Medicaid covers the microarray, covers some panels. It does not cover whole exome sequencing, for example. And then as we go through the current political climate and the politicians deciding what health insurance we need and whatnot. So many of these things, and that's the importance of getting genetic counseling, because some of these things will, determine the cause of the problem, but I don't know what's officially pre-existing condition or not. Obviously, it's in your genetic information, so you would have been born with that. So, and as we transition to the second topic, this is my one cartoon. So this here sisters are talking, and she's saying, well, when I asked what little girls are made of, I was hoping he would say sugar and spice. And he said, no, Genome project. Anyway. So the second part of the talk is about genetic causes and non-genetic causes of congenital heart defects. So we have reviewed the numbers, but in general, you guys have the t-shirts 1 in 110, roughly we're gonna say 1% as far as the frequency of congenital heart defects for simplicity purposes. So we know what happens, we just don't know exactly why it happens. But as you can imagine, congenital heart defects are the result of something being messed up, an alteration or perturbation of the normal programming that was supposed to happen for cardiac development. So, and there's different ways to classify congenital heart defects as far as severity, and I'll show you at least the anatomical part of it. We think that about 1/3 of the patients with congenital heart defects are qualified as severe, and that's important from the genetics perspective, because severe cases are probably more likely to be genetic in origin. So from the anatomical perspective, from left to right, you have, again, little holes in the top and the bottom. ASDs and BSDs are, again, on the less severe end of the spectrum, and then you go all the way to the right to the hypoplastic left heart, as we've taught today throughout the day of different treatments and whatnot. So this is one of the main things to remember. So most cases of congenital heart defects are what we call sporadic. That means there's nobody else in the family that has had it. There's nothing else going on other than the heart. So that's one of the main take-home points. Just to mention, there are a variety of non-genetic causes of congenital heart defects that we know for a fact. So for example, maternal diabetes, obviously, especially if it's uncontrolled, infections, especially rubella. There's other maternal conditions such as PKU, phenylketonuria, which is an inborn error of metabolism. Some medications, including retin-A, which is acne medication, indomethacin, which is used for inflammation, and potentially some seizure medicines. There's a lot of controversy as far as which ones will that be. So this morning we review, or the cardiology group had a slide on the timeline of the surgery part of it and how much improvement we've made over time from the surgery perspective, so not to be left behind. So there's a timeline for the genetics advances that there have been over time. So it actually started about the same time, meaning late 40s, when the first report of congenital heart defect and genetics came about. And then we actually moved forward to really mid to late 90s is when we first found the first mutated genes, either for syndromes or no syndromes related to congenital heart defects. And then this is, again, moving forward to where we are now. So, and of course, at the bottom here, the arrows represent just how technologies have been incorporated. So as technology advances, of course, we are going to keep finding more and more things. So this is kind of where we are now. So ES is whole exome sequencing. Again, we're using that more and more to try to determine the genetic component of congenital heart defects. So that's kind of where we are now. All right, so what do we know? So what evidence do we have that congenital heart defects are indeed or have a genetic component? So for starters, we talk about frequency about a 1%, right? So that's the baseline frequency. So for anybody that has had a child with a congenital heart defect, that jumps to about 4% for the second pregnancy, okay? And then if there are 2 children with congenital heart defects, that jumps to 10%. So you see that there's an exponentially increase, suggesting that there's obviously a stronger genetic component for that family. Second thing is that there are some types of heart defects that are very more likely to happen again within that family compared to other types of congenital heart defects. So there's some clustering that we call. Also, we know that identical twins, the chances that the twin will have a congenital heart defect are much higher than those that are fraternal. So that shows you that there's a stronger genetic component. And similarly, when parents happen to be closely related, consanguinity that we call, cousins or more, there's a higher incidence of congenital heart defects. So those are all pointing that, okay, well, really there's a genetic component here in congenital heart defects. All right, so as I said, the majority of congenital heart defects are sporadic, okay? So you see a pedigree here at the bottom. So the blue means this person's affected, there's nobody else in the family, it's just that person, okay? This is, again, for all congenital heart defects. So as a whole, if you were to do genetic testing in the setting of a sporadic congenital heart defect, unfortunately, we are not likely to find the answer the majority of the time. So if you do microarrays, which is the CMA, or even if you do whole exome sequencing, again, you're looking maybe 15–20% of the time you might find a genetic explanation. The other 80% of the time you either are not going to find it or we just don't know what's going on there. And WGS is whole genome sequencing. So in the ideal situation, that might give us more answers when it becomes more readily available. All right, so now a slightly similar way to compare, you see the difference here. So when there's more than one person in the family affected, so we have dad, a son, and a daughter here, that you're more likely to find a genetic explanation there, so closer to 50% of the time. And then on the right side, if you have a congenital heart defect with ECA's extracardiac anomaly, so if you have congenital heart defects with other birth defects, those are about 50–50% of the time. Either you do a microarray or you're doing whole exome to try to figure out what's going on, so about half the time. So the more problems that child has, the more likely it is that it will be genetic and that you're going to find it. So, and this is the sort of compile of all that. So the bigger portion of the pie, unfortunately, is the unknowns. So that's kind of where we are now. So if you combine the unknowns with the environmental, which is the green one here, that just leaves this portion of the pie, which is about a third of the time you're going to find something genetic, again, as a whole group. So either chromosomes or mutations in your genes, depending on that. So we know out of the 20,000 genes that we have, about 400 of them are implicated with congenital heart defects. So that's kind of where we are now. And this is really just to show you, as far as every center and every geneticist and every CVICU probably have different protocol as far as when to do genetic testing. So just to give you an idea, it depends on the type of heart defect, what type of other birth defects there are, the family history, what testing was done prenatally. And depending on that, we base it on that, again, to decide kind of what you need to do, because a lot of times if you're suspecting Down syndrome, then you just need to do a karyotype and then you're done. Similarly, if you're suspecting, specific genetic conditions that can be tested for by FISH, then you will just do that test. And then the next level, or the most common really test here, will be a microarray. And if that still doesn't give you the answer, then you probably move to whole exome sequencing, again, depending on a variety of things. All right, so prior to the last part, so he's saying, we finally have it all mapped, we just don't know where to lead us. So, which is true. So we are learning all this information, but so what? So that's what I'm trying to explain in my last couple of slides. So the implications of the genetic diagnosis. So why is it important? All right, so somebody was asking this morning about Down syndrome and congenital heart defects. Could that have a negative impact? The answer is yes, which that was the what she was saying as well, which is a risk factor. So in general, having an underlying genetic condition will be detrimental in a variety of ways. For, I would say, some cases, not all the time, but it is a risk factor indeed. So it does contribute to neurodevelopmental, independently of how well the surgery goes or how much 100% oxygen you have throughout your surgery. It also affects your surgical outcome. Just to mention the example of Down syndrome, if they have a tendency to bleed or to be more likely to have infections or whatnot, that will have an impact on the surgical outcome. other medical problems, using the same example, Down syndrome, if they happen to have low thyroid or intestinal blockage, of course, that will complicate everything from the surgical perspective. And staying with the Down syndrome example, they are by itself Down syndrome, even without a congenital heart defect, they are more likely to be smaller and thinner in general, so they have their own growth charts for that reason. So having an underlying on top of the congenital heart defect, a genetic diagnosis a lot of times has negative growth implications. Of course, if I'm able to tell you what the cause of the congenital heart defect is, then I'm more likely to be able to tell you what to expect, how likely would this be to happen. So there are some genetic counseling implications. Family planning comes into play. You know, if you know what it is, again, I can tell you, well, you could test this before you plan, if you go through IVF or you do prenatal testing. And then, you know, there might be some treatments that we can tweak depending on what the underlying genetic diagnosis is. And the most exciting part of it, from the treatment perspective nowadays, is what we call genetic modification. And if you haven't seen it, you will see it because it's coming out left and right these days in the news. So these are from CNN and NPR and whatnot, with a newer technology called CRISPR, which is very promising. And what it does is you're trying to basically fix mutations. But that, I mean, it adds another layer of complexity as far as ethical implications and whatnot, which we're not going to have time to review. So it looks very promising, but even as we were discussing earlier this morning, you know, if the Berlin Heart took 20 years for the FDA to approve it, I don't know how long will this be before we get into clinical trials and whatnot. Just know that is there, it's promising, and you're likely to keep hearing about it as time moves on. All right, so here are my references, and that should do it. Thank you so much.
Thank you. Now you're going to say your name.
Thank you.
Oh, thanks.
Thank you so much. We appreciate it. I didn't get to thank Phil because Phil rocks, and my first microphone that I had was so thanks, Phil. You rock. All right, the next wonderful speaker that we have is Dr. Macula Gray. Yes. Macula Gray. Gosh, I hate slicing people's names. We are very excited. You look well rested. Well rested. His area of expertise includes complex cardiac surgery with a particular focus on adults with congenital heart disease, aortic root and aortic arch aneurysms, congenital aortic disease including Marfan syndrome and Louis-Dietz syndrome, aortic valve repair, and reoperative cardiac surgery. His philosophy of care embraces a multidisciplinary team-based approach to providing the most up-to-date, individualized patient focus. Take it away.
Thank you very much. I have to say I am honored to have been asked to speak with you today. It's really a pleasure to be with you and meet many of you. As the previous speaker said, I mean, this really has been a journey. My role in the next 20, 25 minutes is to try to give you a little bit of the piece of the journey of adults with congenital heart disease. As I think you learned about in the last couple of days, it's been really incredible. Queen Elizabeth has been Queen of England longer than open heart surgery has been possible. Really is amazing. And this is a slide, this graph shows what the likelihood is of survival by decade if you were born with congenital heart disease. So if you were born in the 1960s like me, if you had complex congenital heart disease, there's a 15% chance that you'd survive to be an adult over 18. And if you had transmission to the great arteries, that was 1%. If you had tetralogy of Fallot, that was 10%. And the progress that we've made along the journey has been truly remarkable. And I think that a great deal of credit goes to the pediatric cardiologists and cardiac surgeons who have made that possible. Such that now there are more adults living with congenital heart disease than there are children living with congenital heart disease. And that number of children has stayed over the years pretty stable, but the number of adults continues to increase and rise. So with that comes some challenges that yesterday's solutions have created more challenges for us. At the risk of taking away some of the magic and the mystery of heart surgery, the heart is basically a pump. It's got plumbing, it's got electricity, and it's got power. And that there are many things that can happen over time, particularly after it's been fixed as a child, that can start to wear out, if you will. The sequelae of the native lesions, the plumbing, very commonly, whether it's the vessels or the conduits that we use or the valves that become narrow or stenotic, they become incompetent or leaky. Sometimes these conduits get holes in them. Arrhythmias. What keeps our heart functioning in a very efficient and effective manner is the synchrony that the electrical system in the heart maintains. And that can, as we know, over time, start to wear out. And heart failure, the power. Having the engine, if you will, that pumps blood with oxygen to the lungs and to the body. The consequences of any of these problems can result in other organs becoming involved. You're making a patient with a sick heart have a sick body. And then something that's becoming more and more evident are the risk of developing acquired heart disease and other adult type diseases that further compound and make the challenges of congenital heart disease more difficult. So over the years, there have been a number of questions that families ask me. Why would an adult need congenital heart surgery? That's surgery for children. I thought my heart was fixed. Why would more surgery be necessary? Is having more surgery possible? Is each subsequent surgery more dangerous? The heart-lung machine, that scares me. What is it, and do I really need to have it? What valves are best? What are the risks? How long do they last? How about arrhythmias? I've been hearing more and more about those. Are they a problem? And do I need to worry about them? How about the failing ventricle or the failing ventricles? What is it that can be done for me if I have one of those? Well, the indications for adults with congenital heart disease, they vary. And what you do depends upon the indications. There are some people, remarkably, that are diagnosed with congenital heart disease as adults. Their lesion that they were born with goes unnoticed or unrecognized, or it was recognized and nothing really needed to be done to it or for it. Natural history of repaired or corrected lesions, the natural history of palliated lesions, and then as we talked about a little bit, what do you do about patients who have congenital heart disease that start to get what is the most common cause of death in the United States and other developed nations? That's acquired heart disease, coronary artery disease, valvular heart disease, and so forth. If you look at this slide, if you look really closely, you might see a 35-year-old social worker. She's getting ready to run her 5th marathon. The Philadelphia Marathon's in November. It was unseasonably warm that year, but she's a very seasoned athlete. She gets to mile 24 and she collapses. She's pulseless. She's not breathing. Fortunately, she was running alongside one of her friends who was a nurse practitioner. And fortunately, she was lucky to collapse in front of an EMT truck. They resuscitated her and they brought her to the hospital. Why would a 35-year-old woman, good shape, athlete, collapse? Well, there was a study done by a fellow named Eckert. He looked at over 6 million military recruits. And he looked at these young, healthy, young people with seemingly not a care in the world. And looked at, there were about 126 of those soldiers and sailors and Marines that dropped dead without any trauma. And the leading cause of death for them was undiagnosed congenital heart disease. And the leading cause of that, undiagnosed, were problems with the coronary arteries, anomalous coronary arteries. I would say that in my time in medicine, what has changed the most and has made the most impact is the changes in imaging that we have. I was a medical student, you look at things and it kind of looked fuzzy and you couldn't really tell. We now have imaging that looks like what you see in the operating room. So this is a CT scan that shows, this is of the woman, the runner, and there is an abnormality in her coronary arteries. This line right here is her left main coronary artery. It's supposed to come out right there. This comes off the front of her aorta, goes between her pulmonary artery. And there are other things that we've learned over the years that put it at high risk. It certainly was for her. Why her 5th marathon? Why mile 24? Who knows? But it's a not common, but not an uncommon cause of sudden death in young people. So we did the usual ways we take care of coronary artery disease we've learned over the years don't work very well. So in her, we did what we call an unroofing. We took part of the aortic wall off of this tunnel and made a new opening for her coronary artery. And about a year later, we got a CT scan, and this is the left main coming off the aorta here. It did start out over there, and this essentially represents a cure. We recreated what should be her normal heart. But many of you sitting in the audience, I imagine that many of the reasons that the main reason that you're here is that you do have known or you care for and certainly care about someone with congenital heart disease and perhaps have already been repaired. And so I'm going to spend most of the time talking about patients who have had repaired or corrected lesions. And over the years, our focus on how we do surgery on young people with congenital heart disease has changed. Initially, it was all palliation. Palliation is you don't fix the underlying problem, you fix the physiologic problem. If there's not enough blood flow going to the lungs to get oxygen, you connect an artery that goes to the arteries of the lung so you get more oxygen. If there's too much blood flow going to the lungs, you put a band around the artery to decrease the amount of blood flow. You change the physiology, you don't change the anatomy. With the advent of open heart surgery, more and more, we thought we were doing corrective heart surgery. Like this past woman, we thought we were correcting, curing the lesion, leaving no residual problems. But most of what we do is referred to as reparative heart surgery. Even though we direct our surgery towards the underlying anatomy, oftentimes, either knowingly or unknowingly, leave some residual issues or problems that can, as people get older, come back to need further stuff. So I could have chosen any number of complex congenital lesions. We're going to talk a little bit about tetralogy of Fallot. It's one of the more common complex congenital lesions, and I think that there are a lot of messages that we have learned about congenital heart disease. With all due respect to our previous speaker, the timeline goes back a little further than that. I mean, the knowing what tetralogy of Fallot was goes back to the 17th century. That guy on the top, Nicola Stenson, was a monk, and he recognized tetralogy of Fallot even back then in the late 1600s. It wasn't until the late 1800s that Dr. Fallot in France actually gave it the name. And it's tetralogy, it's 4 things. So the septum between the right and left ventricular outflow tracts are abnormal, and you have the aorta overrides the septum. That creates a hole, a ventricular septal defect. That overriding septum into the right side causes an obstruction to the right ventricular outflow tract, which causes resistance and results in the right ventricle muscle becoming hypertrophied. So that's the tetralogy of Fallot. The end result is the lungs don't get enough blood flow. In the hole in the heart, blood shunts from the right side to the left side. and it was referred to very commonly, certainly when I was a kid, causing blue babies. There's a really very nice HBO movie, Something the Lord Made, that talks about tetralogy of Fallot. And that movie talks about this very unlikely team that made some of the biggest inroads into taking care of congenital heart disease. This is the group, of course, at Johns Hopkins. And it consisted of 3 people. Up at the top is Alfred Blaylock. He was the very prominent chief of surgery at Johns Hopkins at the time. The woman that recognized it, Helen Tausig, at that time was very uncommon. She actually was hearing impaired. Very few women at the time in the field of medicine, let alone cardiology. And she made had an epiphany, moment of clarity, where she said, "Geez, I think this occurs when the ductus arteriosus closes. If we created a ductus arteriosus, we could fix it." It was left to Vivian Thomas, an African-American lab tech, who essentially came up with the concept and developed it in the laboratory, for which he got very little credit, certainly at the time, but he was the brains behind that operation. But this was a palliative operation. It increased the blood flow to the lungs. It didn't really fix the problem inside the heart. Well, what is the challenge with doing open heart surgery? Why don't we do it all the time? There was a famous surgeon in Vienna about a little over 100 years ago that said any surgeon that would operate on the heart should lose the respect of their colleagues. Maybe there is still some of that goes on, but their problem is the heart's full of blood. If you cut into the heart, all the blood will come out very quickly. You bleed to death. If you stop the heart to try to prevent that, very, very quickly, within 6 or 7 minutes, if you don't have blood flow going to the brain starts to get damaged. And by 10 minutes, your brain will likely not survive. What if you bypass circuits around the heart? Well, you don't get blood going to the lungs, you don't get oxygenation and ventilation. Of course, you have to keep the blood from clotting. There was a surgeon from Philadelphia who, when he was a resident, came up with the idea of a heart-lung machine. He worked for over 20 years, every day, trying to develop this thing, starting in the early 1930s. And it wasn't until the early to mid-1950s that he actually started to try to use it. He used it 4 times, over 20 years of work. And 3 of the 4 patients, children that he operated on, died on the operating room table. 1 survived. He got so discouraged, he gave it up. Not just the heart-lung machine, heart surgery, totally. He thought it was an unsolvable problem. There was an incredible person, an incredible surgeon in Minnesota, C. Walt Millehei. He was certainly a maverick of sorts. He was given the diagnosis himself of what was thought to be a lethal cancer when he was a resident. So he didn't have time to wait for the refinements of the heart-lung machine. In fact, he made the observation that why do we need to develop a heart-lung machine? There are heart-lung machines all around us, walking and talking, other people. And so he operated on, in the year of 1954, he operated on 49 children. And to do open heart surgery, some of them very complex open heart operations, he connected these children to one of their parents, using those parents as a heart-lung machine, and had remarkably good results in terms of survival at the surgery and going on into later life, where they not only survived, they thrived. The heart-lung machine now has been further developed and refined. It's used thousands, if not 10,000s of times a day around the world, making heart surgery safe, effective. It's a good thing, not a scary thing. You have to know how to use it. You have to understand it. But we can keep people on the heart-lung machine for minutes and hours, as long as we need to carefully and effectively operate on heart. So it's not something to be worried about. it's something to embrace. It's a good thing. One of the people that made that possible is another surgeon from Minnesota, a fellow named John Kirkland. And he is along with other surgeons around the country and the world, moved the field of open heart surgery forward. And with tetralogy of Fallot, he and others performed the corrective operations. They made incisions in the right ventricle. They used patches made out of cloth, really, the septal defect, and open up the right ventricular outflow tract. And with the use of the heart-lung machine, these kids survived. And they looked at their series over a period of 25 years. And these curves, what they show is that the survival rate up to 25 years was excellent. And they thought this was a cure, this was a good treatment. We have these 25 and 30-year-olds on the head, send them on their way, you cure it, have a nice life. Well, unfortunately, that didn't last. When I was a resident in congenital heart surgery, it was well known. Part of that operation involved making the pulmonary valve, the one-way valve between the right ventricle and the arteries going to the lungs, the pulmonary arteries. You either removed that valve or you made it incompetent, and it was a very leaky valve. The dogma was you didn't need it. Didn't have to have a competent pulmonary valve. You know, we get 25 years of experience. These kids do fine. These adults, they become adults. Not a problem. Don't worry about it. And well, what we found that over time, and interestingly, if you look at the curves up to 20 years, 25 years, the curve looks pretty good, just like the curves from the Mayo Clinic. But then they start to fall off, and they start to fall off in a very concerning way, in that these leaky pulmonary valves are a problem. We never really had to experience that before because, unfortunately, none of these kids lived long enough that it was a problem. So one of our previous solutions now has become one of our problems. And we've gone from thinking that almost none of these patients need to have their pulmonary valves replaced to now our thinking is probably most, if not all of them, eventually will. We've learned some things. Now for babies, we've kind of modified whenever we can how we do that operation. We try to save the pulmonary valve whenever we can. We try not to make incisions in the right ventricle whenever we can. I suppose we're going to have to wait another generation before we find out whether that was effective or not. But what do we do about the other patients? Well, we're coming up with guidelines rather than waiting until these adults with a leaky pulmonary valve get sick. We're learning more and more, getting better and better at trying to figure out when to intervene and replace the valve. So what's the best way to replace the valve? Well, there's a number of different options. And I was once told by one of my professors in medical school, in medicine, whenever there's options, that means there's no great solution. Because if there were, there wouldn't be options. And I think that I look at this a little bit differently. I think all of the different kinds of ways, the different prostheses to replace heart valves, they're all very good. They all have their own strengths, they all have their own shortcomings, but they're all excellent. And for me, one of the things when I'm talking to a patient or family is to look in the face when they're trying to decide what kind of valve they want. I tell them, I say, look, this isn't, I mean, they're all good, you can't go wrong. All of the valves work very, very well. That the question is durability. Certainly when we get to adults, it's durability versus the need to take a blood thinner, an anticoagulant. The mechanical valves are probably more durable. The tissue valves don't require that you take lifelong anticoagulation. No matter what kind of valve you use to replace in the heart, there is a risk of infection, and you will need to take antibiotics prophylactically over life. Activity, both valves, all kinds of valves. Kids, adults can be active and athletic. If they're on any coagulation, just have to be a little more careful about it. We've made a lot of progress in the ability to repair valves. We've got 30, 35 years of experience repairing mitral valves, tricuspid valves, aortic valves. Pulmonary valves, not so much. And the dictum is a good repair is better than the best replacement valve we have. We think that the durability may be better. You don't need to take anticoagulation. There's less risk of infection. And it's probably better, the heart probably works better with your own valve that's repaired. That being said, a good replacement is better than a bad repair. If you can't, as a surgeon, repair the valve so that it's working very well at the time, and we do have ways to assess and predict the durability of these valves. If it doesn't look like it's going to be a good repair, replace it. The good news is that the technology of transcatheter valve repair is rapidly moving forward. We may, in the very near future, not need to do open heart surgery to replace valves anywhere in the heart. The first transcatheter valve that was developed for pulmonary valve replacements. This is the Mended valve, and for many of our patients that need to have their pulmonary valve replaced, we can use this. These are just some pictures of the number of transcatheter aortic valves that are under development or in use today. The same thing is being said for the mitral and tricuspid valves. I mean, it's probably the most disruptive, in a good way, disruptive technology that is in medicine in my lifetime. And similar to the graph we had when we started, if you look at, if you or your child were born with tetralogy of Fallot, if you look at the likelihood of survival, I mean, it has dramatically increased over time, dramatically. How about those arrhythmias? Well, arrhythmias as we get older become more common. If you're born with congenital heart disease, whether it's repaired or not repaired, the likelihood of developing atrial arrhythmias is about twice as high as opposed to patients who don't have congenital heart disease. And the consequences of it are real. It increases the risk of stroke. It does decrease the efficiency of how well your heart works. And for people with congenital heart disease, it's associated with further need for increased admissions to the hospital with heart failure. The heart's an electrical organ. It's kind of interesting, at the risk of sounding kind of gory. If you cut a heart out and take it out of somebody, it continues to beat for a while. It has its own intrinsic electricity to it. And the electricity starts normally up by high in the right atrium, and it goes in an electrical wave in a very coordinated, synchronized fashion through the atrium. And then it only has one doorway into the ventricles where it transmits its electrical signal. For people who have enlarged atria or diseased atria, there's the possibility this red circle represents, if you will, a short circuit in that electrical circuit. They can get these what we call macro entrant circuits that cause atrial dysrhythmias and atrial fibrillation. It takes away the efficiency of how well the heart beats. And there was a fellow at St. Louis who thought, well, you know, maybe if we could make lesions inside the atria, a maze, if you will, like a rat maze. And so you make it so that there's no really big sections of the atrial tissue left, so that only the signal that starts where it's supposed to can make it to where it's supposed to. Like the lucky rat finding the cheese. And he developed this very complicated operation called a maze procedure that involved a lot of cutting and sewing. It's a big operation, but over time, in the last 15 to 20 years, it's become much simpler. We can use, rather than cutting and sewing, we can use radiofrequency or cryocaths to make these lesions for open heart operations for patients who have atrial arrhythmias. And it can be done very effectively in the electrophysiology lab in patients who aren't having open heart surgery. And it can be done on both the right and the left side of the heart. This is particularly important to patients who have had palliated operations, like Fontane's. This is a picture of Francois Fontaine, is a French surgeon who developed the operation for tricuspid atresia. As many of you know, there's a whole number of different cardiac lesions that result in what's normally supposed to be two ventricles pumping, the one on the right, morphologically right to the lungs, the one on the left to the body, the systemic ventricle. And either one of the ventricles doesn't form, or doesn't form well, or doesn't work well. And so Francois Fontaine developed the cavo-pulmonary connection, and the concept of that was to whatever ventricle or combination of ventricles you have, turn that into the engine that pumps blood to the body, and surgically reconstruct the veins, bringing back blood from the body to go around the heart directly to the blood vessels, the pulmonary arteries going to the lungs, and use the lungs as you breathe as the lung pump. Now, over the years, we surgeons and cardiologists refer to these as the Fontaines, but there's been a number of different iterations done on this. The old Fontaine was sewing the atrium right to the pulmonary artery, but there have been lateral tunnels. You take a piece of prosthetic material and sew it inside the right atrium to create a tube within the heart, or an extracardiac conduit. We have, as I said about the advances in imaging, we have the ability now, using four-dimensional imaging, to look at flow. And this is a CT scan, a 4D CT of a patient that had a Fontaine. And the blue blood's coming down from the superior vena cava, and the yellow is coming up from the inferior vena cava. It doesn't take an engineer to realize, well, geez, you know, that's not really efficient blood flow. You've got these two columns of blood kind of hitting each other like the crashing tides. And that it confirms what we had known, that there's, in some people, there's ineffective or not ergonomic energy transfer of the blood flow. And this has allowed us to figure out better ways to create the Fontaine, and better ways to figure out in patients who have already had Fontaines how to revise them. They're prone to develop atrial arrhythmias, and they can have big, whatever their atrial construct had been, have bad ergonomic transfer of energy. And there's been very good results in some centers with these Fontaine conversions or total cavo pulmonary conversions to try to get the patients out of atrial fibrillation and improve the blood flow forward. It's a big operation, but the results have been very, very good for patients. Well, how about the ventricles that are too sick to get better? They can't surgically or medically get them better. A lot of progress has been made in the field of mechanical circulatory support and in heart transplantation. Not that it is, I mean, in many ways we think of it as the end of the line, but for many people it's the beginning of a new journey. I mean, it really is remarkable what we can do. Most of these pumps, these implantable pumps, were designed for people with acquired heart disease. But the pumps are getting better, they're getting smaller, and they can be implanted. I put one in a woman not with congenital heart disease who lived with one at home for 11 years. And she only had to come back to the hospital in that 11 years for checkups. She did very well. There's increasing experience using some of these pumps for patients with congenital heart disease, and the results are actually quite good. This year is the 50th anniversary of the first heart transplant. As many of you may know, it was done in 1967 in South Africa. And that pretty simple concept, heart doesn't work, take it out, put in a new one. As I said, I mean, it is remarkable how well that works for someone who has a failing heart. The challenge is that there aren't a lot of hearts, and we're trying to figure out a way to increase the amount of donors. But the patients do extremely well. There was a time when patients with congenital heart disease had poorer outcomes for a number of reasons. But the experience has gotten better and better. My friend Brian Cogan, when he was at Emory, reported had incredible outcomes with heart transplants in a center that an adult congenital heart disease center. And I do think, I know you heard some talks earlier in the program about the transition of care. And I do think that patients living with congenital heart disease, when I was doing my pediatrics rotation, it's commonly said that children are not small adults. I think the converse can be said, that adults aren't big children either. They have issues that are different from pediatric issues that are well cared for a team that's used to taking care of adults. And there is some data to suggest that long-term outcomes are better in similar centers. So I'm going to finish up by saying that it's been very exciting to be part of this journey in just my own professional lifetime. The successes judged by or measured by people living longer, living better, and thriving has been absolutely moving for me. There are more adults than children now living with congenital heart disease. It has created new challenges, but as I hope I showed you, man, thank you for indulging me. I like history. I learned a lot, not only information, but inspiration from learning about people, extraordinary people, who face difficult challenges and solve them. And I can promise you that many of you who have children with congenital heart disease, just like there have been many people over the years who have focused their attention in solving those problems, there are also people who are focusing their attention on getting patients with adult congenital heart disease to survive and to thrive. With that, thanks very much.
You know, whenever he brought up this slide of not knowing how long that was going to last, I can remember where I was whenever my cardiologist, Dr. Hurwitz in Riley, called me, and he goes, "What are you doing?" And I was 28, and I go, "What do you mean, what am I doing?" And he goes, "I need to see you back." And that's when he decided that I was going to have my 4th open heart surgery. So with our adults, we just didn't know they would make it this long. So thanks to you, it was wonderful. All right, our next speaker is Kristen Sexton. I know you're around here. There is this pole here you cannot see. Welcome. Her interests lie in cardiac imaging, indulging in transthoracic, transesophageal, and fetal imaging, inpatient care and continuing care of children with acquired and congenital heart disease. She hopes to expand her research endeavors, both at a local and a national level, to include preventative cardiology, quality improvement, and outcomes of children with acquired and congenital heart disease. Welcome. Thank you.
Okay, so with that introduction, it doesn't really make sense that I'm talking about nutrition. So that was written actually about 5 years ago, and it's very true. I still do all of those things.
Trying to come back up
But, no, that's quite all right. I was actually going to say this anyway, because my interests have really changed. I work in the Center for Preventive Cardiology, and while I still do imaging, I think my love is really in preventing adult onset heart disease in kids. And I think kids with congenital heart disease are in this group of kids that we need to prevent this in. They're actually probably at a higher risk than kids without heart disease. They've had to have heart surgery. Many of them, as previous speakers have talked about, have coronary artery anomalies, or they've had surgeries that have involved the coronaries. So I think it's very important. So I am not a dietitian or a nutritionist. So this is not going to be the standard kind of nutrition talk that you'll hear from a dietitian or nutritionist. I am a cardiologist and a preventive cardiologist at that. So we're going to talk about stuffing them full, nutrition in early life, and what problems that can cause, not always. And then we're going to talk about what we need to do after we stuff them full by thinning them down, and then kind of go through a little bit about nutrition in the ages, and then talk about a potentially better approach, at which time I'm going to ask for your help, hopefully. So neonatal nutrition in congenital heart disease. Many kids with congenital heart disease, babies, infants, neonates, have problems growing. They either have inadequate intake, they're breathing too fast, they can't get enough calories in. When you breathe faster, you need more calories. They can't use the food that they eat appropriately, they spit up a lot. They have all sorts of problems that make their nutrition more difficult. So what do? We stick tubes in them, we force feed them 30 calorie an ounce formula. Normal formula is 20 calories an ounce, let's be clear here. We're force feeding them large volume, 30 calorie an ounce formula, just to get them bigger. Well, yeah, they do need to grow, I agree. So sometimes we do need to do that. But what is our goal? To what end? Well, a lot of times it's a surgical definition of adequate weight for the intervention that's going to be done, or something of that sort. If it's easier for the surgeons to do on a bigger kid, by all means, I want the kiddos to be bigger. But is it the right kind of weight gain that we're getting? Not sure. So we're trying to stuff them full. There are so many protocols. I was going to try and put them all up here, but my computer crashed and I tried to put all different pictures and have them fly in. There are protocols, and more protocols. Every different form of congenital heart disease has a protocol for neonatal feeding. VSDs, ASDs, everything. Big complex stuff, heterotaxis, hypoplasts, everything. So this one's a transposition. This one's a general congenital heart disease patient. This one's for hypoplast right after their initial operation. This is for hypoplast during the interstage. So one of the things with all of these, as I was looking through them, the nutrition red flags all look at weight loss, failure to gain weight, poor intake. Yeah, that's a problem for some kids. By all means, I take care of kids in the hospital on a very regular basis where that is what we're focused on. But it's not a problem for all of the kids in all congenital heart disease. You only get into nutrition support if you are not eating enough. And you get out of nutrition support if you cross growth curves going up. Then as long as you crossed a couple, you're out of nutrition support. Doesn't matter if you cross 15. Once you head in that direction, that's considered out of nutrition support needs. So I got these offline. These are all of the kids that we know and love. Some of these, hopefully not any of your kids, but I did get them online, so they're all public pictures. Which of these kids have heart disease and which don't? I can guess one does, because there's one with a scar. There's a blue one, so we've got a couple that have congenital heart disease. What do you think about the one with the nasal cannula? I can't tell. There may be a scar there, but I'm not sure. And the other one I can tell you doesn't. But they all look about the same size. So we're force-feeding kids that may not need to be force-fed anymore. So I'm not really going to focus on the neonatal period. We're going to move on to toddlerhood, early school age. They look like pretty healthy kids to me. But have we told them that? Have we told them that they need, as the cardiologist, have we said, you don't need to be force feeding your kids anymore, you don't need to be adding the extra oils? Most of my colleagues that I talk to about this, at least, say no, that we don't tell them. Then we go to activity, and we are trying to keep them out of softball, baseball, soccer, basketball, dance. Why? Because we're worried about their heart. Well, I'm worried about the heart, but I'm also worried about this and about becoming an early child who has a hard time, the toddler who comes into my clinic or other people's clinics that's 48 pounds and 18 months old, the teenagers that are developing bad habits and not active and sedentary. So let's switch gears a little bit. Who knows who this is? Hopefully everybody does. Awesome, Shaun White. Olympic snowboarder, amazing athlete, good nutrition, and has congenital heart disease. His tetralogy of Fallot. He was cyanotic at birth. He had to be force-fed for a little while, but then he was able to do this. And I think these are the kids, this is what our goal needs to be. Not everyone's gonna be an Olympic athlete, that's not what I'm trying to say. But we need to allow kids to have these kinds of expectations. Because I think a lot of times, we as doctors don't let kids do the things they wanna do because we're afraid. And as parents, I do the same thing and my kids don't have congenital heart disease. I'm worried about something bad happening to them, so I don't let them do everything they wanna do. I don't want them to do anything that's gonna have a concussion. I don't want them to do a lot of those kinds of things. So he needs to be our poster child for activity and nutrition. So we're gonna kind of focus a little bit on, in a cardiology clinic, general cardiology clinic, after palliation or repair. I'm not a fan of repair because I feel like that says that we've fixed it, and I'm not sure that we really have, so I usually say palliation. So 43% of our patients that we follow for congenital heart disease are overweight or obese. That's higher than the general population. The general population, at least here in Texas, is about 36%. Less than 5% of those patients that we're documenting on carry that as a diagnosis. Now maybe that's a good thing, but what it makes me worry about is we're not addressing it. And 35% of these patients at some point had a normal or a low BMI in the past, and not as a neonate. (22% had their BMI increased by over 20 percentiles while they were going through our clinic. And maybe 20 percentile is what you need, but 20 percentile also could be going from normal to very abnormal. So what are we worried about when we talk about kind of nutrition? We're worried about obesity. We're worried about high blood pressure. New guidelines just came out for high blood pressure that are actually going to make high blood pressure more common in the pediatric population. We're worried about high cholesterol. Cholesterol guidelines vary based on your other risk factors. Congenital heart disease hasn't necessarily been considered a risk factor for high cholesterol, but I think it probably should if you've had to have an intervention, particularly if you have a coronary issue, it definitely should. Things like diabetes or prediabetes, thyroid problems. And then you get into the other things like exercise. We already talked about that. We may limit them. You may limit them. They may limit themselves. Sleep apnea, orthopedic problems, their hips hurt, their knees hurt, and psychosocial problems, their embarrassment, the shame that we talked about earlier. All of those things are related, they're all interrelated. They're all related to nutrition as well. So what can we do? So my goal is to thin them down or at least keep them in a normal range if that's where they started. So I think there's several different things, and you guys are gonna have all seen these pictures hopefully, but there's the healthy plate. The healthy plate rule is half the plate should be filled with vegetables, quarter lean meat, quarter starch. So what size is this plate? This plate is not the charger underneath. This plate is a 9-inch plate, theoretically. So there's pictures like this that goes through exactly what should be in all of these different areas, and they're fairly helpful. I like this one because it actually puts the 9-inch plate on here, and I think that's important, particularly when I talk to kids about their bowl of cereal that they have every morning, and I'm thinking a cup of cereal, and they put their hands out like this. I'm like, that's like a whole box of cereal. Yeah, they go through a box of cereal every 2 days. It is almost half a box of cereal. Okay. So then there's the food pyramid. This is one of the older versions, kind of I mean, I think everyone probably has seen these kinds of things. All of the things you're supposed to have more of on the bottom with the bigger area, and then you get to kind of, this is not the cherry on top, this is the things you shouldn't have very often. But I think a lot of our problems, mine included, is that I really read the food pyramid upside down. So what do we need to do to try and help stop reading the food pyramid upside down? Healthy snacks, healthy foods. Have prepared snacks ready. Have a bag of carrots if kids like carrots. Those kinds of things. Encourage fruit and vegetable over chips and those kinds of easy to grab snack foods. Increase water. That is one of the things that I have found helps more than almost anything. It helps with activity. It helps with chest pain. It helps with school performance. It helps with athletic performance. It helps with all of that stuff. Oftentimes I'm telling people that instead of giving whole milk, why don't we go down to skim milk if you can tolerate it. That's a big drop. Do it slowly if you need to. But I think the other thing is making physical activity a habit and being a good role model. This is really a family thing. This is not something that a kid can do, one child can do when the siblings are getting to drink Cokes and have their chips. It's really something that the entire family has to do. So other food pyramids have been developed. This is a newer one, and I like this one a lot. One, it kind of shows the relative amounts again, but I think the important thing here is that it puts the activity on there, which I think is key. Even in these kids who a lot of times we say maybe you can't exercise, but they actually can. I mean, most of the exercise restrictions are competitive athletics, not can you go out and throw a basketball around, or can you go walk down the street or walk the dog. So kids can't use this as an excuse not to mow the yard. So the nutrients in our food, carbohydrates give us energy, quick energy. Protein kind of helps build and repair body tissues. Fats, they give us reserve energy and insulation. Some of us have more of that than others, unfortunately. And these are the ones that don't produce energy. The vitamins, you have to have them. So you need a good balanced diet that has all the vitamins and minerals that you need. Water, again, can't express enough how important that is. And then fiber, which comes mostly from fruits and vegetables. So I go through kind of all the different things, grains. The problem with this talk for me was every kid is different, and there's all different ages, so I can't really say 3 ounces of grain and 5 ounces of meat and that kind of thing. So it really is a range. And every kid is different. Everyone's metabolism is different. If you or your children are out there running a marathon, you're going to need to be on the high end of this. But if you're relatively sedentary or younger, you may need to be on the lower end of these ranges. But I think the serving sizes in these is important. 1 slice of bread is a serving of a grain, not 2. A sandwich is 2 servings of bread or carb. Vegetables. Please eat as many vegetables as they want. I have told kids many times, if you want a whole refrigerator full of broccoli, please eat a whole refrigerator full of broccoli. You don't get to have the ranch dressing with it or the cheese melted on it, but you can have all the raw broccoli you want. Fruit. I have been surprised at how many kids don't like fruit. My kids love fruit, so that was something that was a little bit hard for me every time I run into it. But it really is important. It gives you nutrients and vitamins that are not in other foods. Milk and calcium, usually it's 2 to 3 cups a day. Try and stick to the lower fat or skim, and then meat. So a serving of meat is about half the size of your palm. Your palm grows as you grow. So half the size of an individual's palm, so kids is a very small amount. That's a serving of meat. And oil should really be limited. So we already kind of talked about activity earlier, so I won't focus much on this, but I do want to say that physical activity is key, at least 30 minutes a day. 60 minutes is even better. And a lot of people, myself included, say, how can we do this? I'm too busy at school, I get up too early, I get home too late, but it's actually not that hard because everything you do counts as physical activity. Walking from here to the parking lot, that's actually can count as physical activity. So if you walk to school, that can be 10, 20 minutes, and you add all those little bits up. It doesn't all have to be at once. So now's where I get to ask for your help. Hopefully this is not what schools are like anymore. So a potentially better approach. And this is, like I said, where I need your help. I believe that this is different. Well, the practice that we have had up to now is that everyone is different. Everyone needs something different. And I think that's true. What works for everyone is different. Finding that little thing, it may only be one little thing that you have to change that goes from an unhealthy diet or unhealthy nutrition to healthier nutrition. But finding that one little thing is all we need to do for each person. But how do we find that? And we've got so many protocols for the little kids. What happens when they get bigger? When you go to the cardiologist, do they talk about blood pressure? When you go to the cardiologist or your pediatricians or your primary care doctors, do they talk about high cholesterol? Do they screen for high cholesterol? Do they talk about activity? I'm sure some do, primary care especially. And I'm gonna tell on us here. Here, we don't. Texas Children's in cardiology, there are not very many of us who do. Not all of us do. And so my goal is to bring this to the broader stage. But I need your help in what works for your kids. Because like I said, it's different for everybody. Is it getting rid of the soda? Is it drinking more water? Is it the whole thing with water a half an hour before? So we are actually actively working to get a group of people together here in the local area, or if we can do it by internet, to look at what we can do, what can we put together to try and make this not a one size fits all, but at least something that would give care providers and families ways of providing intervention that's kind of already there, because we're a lot more willing to follow things when they're already there, as opposed to us having to come up with them ourselves. So we recommend evaluating blood pressures at every visit and discussing it, evaluating cholesterol periodically at least 2 times during childhood. If you've had coronary interventions, it needs to be more than that. Getting some activity, and I think that's it.
Thank you. We're getting ready to bring our last speakers up, but before we bring them up, I want to do a couple housekeeping things. Remember, if you have any questions for any of our speakers, please write them down and post those on the national site, and we will make sure that we answer those. Some of them have already been answered, and then if yours is not answered, we will make sure that happens. Also, if you bought raffle tickets, get your tickets, because after these ladies speak, we will be drawing for the winners. Other than that, I think that is it. Any other housekeeping things?
The dash game tonight, Emily still has the tickets.
We still have tickets. Emily has your tickets for the dash game tonight, so get ready and get your yelling voices on. Ladies, are you ready?
Yeah.
All right. So let's introduce DK Lovett. She is the Cardiology Transition Coordinator at Texas Children's Hospital. Her current contribution to the development of the transition program at Texas Children's Heart Center allows her to combine her career and her passion for teenagers. Her hope is to create a model program addressing both healthcare and the physical social needs for patients and families with congenital heart disease to produce responsible and independent adults. I like that, independent adult. You could work with a couple other people, I think, not just those kids. I'll let you talk to my husband.
We do transition to parents as well.
There you go, there you go. Ms. Nicole Goodley, she is currently licensed in both Louisiana and Texas. Of experience in her field. Her education and career have always focused on her passion for working with children and families. First as a school social worker in the Calcasieu Parish, I wasn't even going to try, school system of Lake Charles, and now as a transition social worker at Texas Children's Hospital. Her experience in case management, psychosocial skills development, anger management, group instruction, supportive counseling, and crisis intervention make her a tremendous asset to her team. Ladies, take it away.
Okay, so I know you guys are like really super excited because we're the last people of the day. But I promise you, Nicole and I talk really fast, so it's going to be cool and everything's going to be fine, okay? So we were asked to speak briefly, which we will, about the unique issues and challenges of the adolescent with congenital heart disease, typically that they encounter during transition. And just for clarity, we're talking about transition. We are talking about the process of becoming an independent, responsible adult. So not the transfer of care, not moving from a pediatric to an adult provider, but the actual process that occurs through the becoming independent, gaining more control of your life, and then hopefully becoming a responsible adult. So Nicole and I see lots and lots of different types of CHDs, lots of different scenarios. We understand everyone matures at different rates with different abilities. However, in our experience, we have noticed that transition typically begins early teens and progresses into adulthood, not necessarily 18, but typically by 21 or 24, we hope to see independence, okay? So for time and simplicity, we're going to just touch on the most frequent things that we see in our current transitioning teens, how we talk or engage them, as well as resources that we typically provide for our families, okay? So we've broken them down into the three major categories: psychological concerns, disease knowledge deficits, and then healthcare skills and weaknesses. Our hope is that we will just start some meaningful conversations in your homes. I'm not trying to cover all of this today, but just that you have kind of a place to start and that you don't feel overwhelmed, and that you also realize that most everybody is going through the same things. So with that, I'm going to let Nicole start us off and tell you what we see with our psychological concerns.
So recent journal articles have stated that approximately 42% of people with congenital heart disease experience some form of anxiety and or depression in their lifetime. Social adjustment, which is how they cope, and patient perceived health status, which is what they think about their health, were more predictive of depression and anxiety than medical variables. So with our current patients, the trends that we're noticing are anxiety and depression, as well as suicide attempts, cutting behaviors, and adjustment disorders. And we know that the majority of the teens will not just come straight out and tell you, exactly what's going on. So we're gonna have to look for signs. And I like this quote that I found from Reed Wilson. He's the director of the Anxiety Disorders Treatment Center in Chapel Hill, North Carolina. And he said that teens have a reputation, deserved or not, for being difficult, moody, and belligerent.
I know we're all shocked by that.
But those same behaviors can be a warning sign that your teen is battling anxiety or depression, because we know that behavior is a form of communication, okay? So how can you recognize the red flags that your teen is presenting? So for anxiety, we know that it can be normal and even helpful in stressful situations, but it becomes abnormal if it interferes with your day-to-day activities. And so some of the signs and symptoms of anxiety that you'll see up there that are most common in teenagers and young adults will be poor school performance. I'm sorry, I can't see. Not poor school, I'm sorry. Physical complaints, sometimes those are considered like somatic complaints. So they may go to the doctor with, say, chest pain or shortness of breath, things like that. Other things they may experience are negative thoughts, excessive worry, difficulty sleeping, perfectionism, self-consciousness, and remaining outside of the normal teenage, self-consciousness and things like that are going on. Behaviors such as nail biting, skin picking, pulling their hair, self-doubt or second-guessing themselves, avoidance of people or situations. And then when we look at depression, it is not uncommon for them as a teenager to be down, oftentimes for different things going on in their lives. But the symptoms of depression kind of come about whenever you notice that these particular signs and symptoms are occurring more than 2 weeks. So things like poor school performance, they're withdrawing from their friends, from family activities. They're sad, they may be angry, more than normal, or they're overreacting to criticism. They're indecisive. There's also, maybe you're noticing substance abuse, or they're restless, they're lacking concentration, or they're very agitated. Those are some things that'll give you some signs, okay? And again, these are all things that are out of the ordinary, not just like your normal, everyday, regular stressful situations. These are things that are gonna last a little longer and may cause some concern, okay? So we're gonna see what DK sees as far as disease knowledge goes.
So most of you will be glad to hear that the majority of our patients are not regularly participating in extremely high-risk behaviors, okay? Not to say that it doesn't happen, okay? But normally that's just not what we see from this patient population, okay? We see basically very subtle inconsistencies in their care. We see, oh, I feel fine, so I stopped taking my medicine. We see them not doing their activity restrictions because they don't understand. So either they're not doing anything because they're afraid, or they're doing too much because they don't want anybody to know that they have the congenital heart disease. So we kind of see, basically the trends are that we really don't know enough, or we don't know what we need to know. So it boils down to a combination of them having just tons and tons of questions, and then also maybe not even knowing that they should be asking tons and tons of questions. So how we find out is, and it's the same thing what we suggest for you guys to do, is to find out what they don't know, find out what they need to know, find out what you should know, and there's lots of ways to do that.
Okay, so first let me remind you that we are very limited in the time that we have to introduce ourselves, engage in meaningful conversations with the patients, and assess the needs and wants of the transitioning families. But fortunately, you as the parent have the luxury of time, but you still may find these tips helpful. So even though you can see quite a few of these things these may be some more sensitive topics than others, but we always try to leave the conversation open for questions and discussion versus just check this box and move on to that one when we're working with our patients.
Yeah, we use these knowledge and skills, but they're called surveys, to address important knowledge questions, relevant healthcare skills. This could be an excellent way for parents to break the ice, which is essentially what we do. So even just having them say a question out loud or read one of these questions to them kind of gives you a way to open up conversations to learn more about how they're feeling, or if they do know about that or whatever. So we use a lot of these types of surveys, very matter of fact. Every single topic that is on the survey, some of them more sensitive than others. We always make sure that we're blunt, but we're very sensitive. Like, this is just the question. We ask everybody the question. There's no reason to get weird about it. And then we're realistic. We want them to know these will be your limitations. You do need to know these things, but then also encouraging them to live to their fullest potential. Like several people have talked about letting them do the activities they can do, because it's going to be really important, especially for teenagers when so many changes are occurring in their life. We don't want to limit them. We want them to do as many things as they can with the exact same as all of their friends, okay? So we try to be very honest, but also encourage responsibility with them. Personally, I have found with teenagers that we not just ask these questions, but we normalize the questions for them. So we also say, some patients have asked, or lots of young adults want to know, and that gives them the opportunity to say, oh, okay, well, if I can ask any question I want, because these people have pretty much heard everything. So one of the best interviews that Nicole and I actually ever did was with a young lady that actually read every single one of the survey questions out loud to herself. And Nicole and I just sat there in awe. Like, literally you could see like the brain and the words like moving, because she was asking herself the question, trying to answer the question, processing the question like, oh, if they're asking me this, maybe I should know the answer, but I don't know the answer. So it was really interesting to see how just a simple survey question can spark a lot of conversation with the teenagers.
Okay, so you can see on the right of the screen our transition queue. These are the typical teen and young adult tasks or skills that they should be working on and that we hope will be accomplished prior to them transferring to an adult provider. So that means they are independently performing these tasks on their own, hopefully with little to no assistance from you as a parent. Some of the patients may not meet all of these tasks, depending on whether or not they have cognitive issues or other disabilities. However, even with accommodations, most of these can be accomplished. And these are all the tasks that we encourage that you can be working on at home with your teenagers.
So as you can see, this probably seems like a lot, but probably one of the most worrisome deficits that I see is patients just not being able to communicate their condition at all. So as a parent, you usually have a folder. You're like, I've been taking care of them forever. It's 10 million pages. I know every single surgery, every single cath, every single everything. And not to discount that, but nobody needs all that, okay? So if you're transitioning a patient and your teenager can't say what they were born with, their final repair, and then how they're feeling at the time, that's significant, okay? So yes, all of that history is important, but what we're trying to do is to empower them and encourage them to take responsibility and ownership of their condition, and it actually can be quite simple, okay? So here's my favorite example. My name is Luke Skywalker. I'm 17 years old. I was born with transposition. I had a switch. Now I'm feeling chest pain, shortness of breath, dizzy, and I need help. How long did that take me? Like 3 seconds? That is our 3-sentence summary, and we really encourage every single one of our patients, starting at 14. Hopefully, if your kid younger than that, start now. But that's kind of our 3-sentence summary that we encourage all of them to do. And what it really, really does is just empower them to let them know what they have, how they can communicate it. It's simple if they get an emergency, that kind of thing, okay? The second most worrisome thing I see might not even be recognized as risky. Some people might not think, oh, that's a risky behavior. But these are behaviors that are a huge part of becoming an independent adult with congenital heart disease. And it's very important that patient and family and friends realize that their teens are probably not dealing with any of these issues.
So the big ones on our list are irregular dental checkups and or no dental care, traveling without medications or knowing where to get emergency care if you need it, letting your insurance coverage lapse, which is a big one, missing clinic appointments and non-compliance with medications or activity restrictions. So what if you recognize knowledge deficits or high-risk behaviors? It gets a little trickier, but we try to advise with caution. Again, going back to the blunt facts of what the real risks are for the patient who has congenital heart disease. Then we encourage them and we say, so let's think this through.
Right, and one of our huge goals is to help our patients become successful and responsible adults by having a relationship based on mutual respect versus we preach to them and they listen. So we encourage our families to do the same thing. Sometimes as parents, we want them so hard to understand what we're saying that it can sometimes come across as preachy or bossy. I've been called bossy. So if we have a relationship that fosters that growth and independence, then even when they make a mistake, we're hoping that they can return to us for counsel. So here goes our approach.
So the approach. So the first thing you want to do is be attentive to your teen's behavior. Notice any dramatic or abrupt changes in their behavior, which can be strong indicators of issues. Curb your own anxiety. According to an article from the Washington Post, 65% of teens who have anxiety have a parent who also has anxiety. So as you overcome your own anxieties, talk to them about what has helped you. Be careful of your body language. Keep communication constant, open, and honest. Offer help and listen. You want them to feel comfortable in coming to you if they're indeed dealing with some type of issue. Word choice. That's a big one. You want to encourage rather than just give directives. Okay? So we don't want to lecture. All right? Resist the urge to fix their problems for them. If your teen asks you, if they ask you what they should do, it's good for you just to reflect the question back to them and help them work through the problem. Because if you're not there, they'll need to know what they need to do. okay? Also, trust your instincts as a parent. And then the last thing is just get professional help. We have a lot of good resources for that. And then these are our references and resources. We use the Got Transition website a lot. We also use iHeartChange.org, which is excellent. It brings them through basically everything that we educate them on when they're in the process of transition. And then there's the Adult Congenital Heart Association.
And lastly, we just want to offer encouragement. Sometimes monitoring subtle inconsistencies. Are they taking their medicines? Are they not taking medicines? They tell me they're taking their medicines, but then they look like they're not taking their medicines, so I'm not sure. And they're supposed to be independent, but they're not independent because they're not calling me when they're supposed to call me. And it just goes on and on and on and on as a parent. So I think the most important thing is to just keep that line of communication open between parents, and then also know that you do have resources out there. Contact your social worker, contact your nurse liaison, get involved with anybody and everybody that will listen to you and offer help. Okay, so they have lots and lots of questions. Our teenagers that we see every day have so many questions, and oftentimes they ask us because maybe they feel like it's not really important, or the doctor doesn't have time, or maybe it's a silly question, or maybe my mom's in the room. So just give them that opportunity to ask questions to their healthcare provider by themselves independently. We know everybody matures at a different time. It might not be 14 when they're ready to do that. You know your child, but if you think that they are, encourage them to have a moment with their provider. Say, mom's going to step outside if you want to ask questions to the doctor. You know, if they don't, who cares? But at least you've provided the opportunity for them. And then lastly, they asked us to kind of put up a what to expect as you're getting older. These are just some of the common tests that we kind of walk our teens through just for you guys to have if you need them. Just a quick example. A lot of times teens, they hear they've got a new test or a different test, and it can be scary. So just providing that information with them so they know ahead of time. You might see this when you become a teen. They might not have had any of these tests for 5 or 6 years, but guess what? They're bigger now and they need different tests. So that's it. We'll leave you with that. Thanks. Thank you.
Great job. You know, I have a funny story because growing up, you know, we didn't have wonderful people like you whenever I was in, and I remember my mom said something, if you have sex, you're going to die. If you drink, you're going to die. If you smoke marijuana, you're going to die. I'm like, really, Mom, am I really going to die? Well, obviously I didn't, so we're good. I'm just kidding. Don't do that at home, people. Everyone, thank you so much for coming. We do have resources.